So we proceed to the next interesting topic, back to breast cancer. But we treat, of course, also men with breast cancer. So it's my pleasure to present Markus Notter from Berne. I think we met for the first time about 20 years ago, and the European Society of Hyperthermic Oncology. And that's why we also invited you to talk about, of course, radiotherapy and hyperthermia. I think I don't have to say more about Notter because in Switzerland, since 2009, we use the Notter schema. But he's a radio-oncologist dealing with breast cancer and hyperthermia. So thank you very much for your talk.
Thank you very much for the introduction. Just to give my disclosure, I don't have anyone, but I'm not neutral because I'm doing hyperthermia for more than 40 years. So I'm still a believer. Why should we use hyperthermia? Just a brief summary about what's the idea to use hyperthermia. If you have a tumor like this with almost visible border, we know that in this mass or in this tumor there are some centers which are badly perfused with central necrotic regions. And if you try to remove that, you can do that with surgery, but you cannot always try or do a surgery. Then we try radiation. Radiation can reduce such a tumor, but we have the Achilles heel. This is the central necrosis. There, these cells are surviving radiation. And the same, you can say with drugs, also there, we cannot reach this badly perfused region. Adding now hyperthermia is the contrary thing, because these are really easily heated. And so we have an additional tool to treat a tumor like this. And in a summary, you can say it's really radiosensitizing and the chemosensitization as well, and also we have some direct cytostatics. I don't want to go too much in these details. Coming back to breast cancer, we have already heard a lot of women are touched by this, about 2.3 million per year in the world, and about 700,000 are dying of the disease. But due to screening and early diagnosis, there is an increasing number of breast-conserving treatments. That means also that in most of the breast cancer cases, local treatment consists of surgery and radiation with a very good local control. And what we have also seen recently is that in early stage breast cancer and favorable situations, elderly women, we can even think about to omit radiation, but with the price of a tenfold increase of local recurrence, which is not, let's say, lethal, but it's a local occurrence. So it looks like that addition of hyperthermia as a radiosensitizer is not really needed, and I can stop here and we can go to the break. But it's not so easy, of course. We have recurrence, and the local recurrence in the breast cancer is a disaster. You see, it is just a brief story of this patient who had the first breast cancer in 1996, was treated with breast-conserving therapy, then a second one 12 years later on, again breast-conserving treatment, and again 10 years later she had a local recurrence in both breasts, bilateral mastectomy and then in adjuvant chemotherapy, and under that the local tumor progression was again there. And the story continues. After X systemic treatments, I'm sorry to show you this, but this is what I see in my clinic, about 30 to 40 patients per year. She had everything we can get, and unfortunately nothing helps. And of course, this is almost too late. And it limits in a horrible way quality of life of such a woman. It's a decaying tumor with odor, with special wound care, social isolation, and so on. If I tell such stories to my colleagues, I always heard the same thing: this is very rare, we don't see any patients. That means these patients are disappearing from all the statistics. Nobody knows a lot about of these women. And can we estimate how many women are really suffering from such a disease? Is this really rare or not? If you go back to the statistic, we see that with all these classical treatments, we have a local regional control which is about 97, 98%. So that means 2.5 to 3.5% are local recurrences. Despite this low rate of local recurrence, the absolute number is increasing because we have more women treated with local treatments of breast-conserving treatment. And if in future we will even omit in early stage breast cancer radiation therapy, there will be even more. This is the price. So local treatment of local recurrence is usually salvage mastectomy after initial breast-conserving therapy, or local excision if possible when there was already an initial mastectomy. And we also know that if it's a high risk situation that local recurrence patients have a T3 to 4 with lymph node involvements, with not radicality of resection or infiltration of blood vessels or lymphatic vessels or negative hormonal receptors, or all of them together. Of course, we would like to add a new radiation if possible, or if there was no radiation, then at least we should think about now to radiate the local situation. And in case of a re-radiation, the total radiation dose are limited. And therefore, superficial hyperthermia can be added and then to improve these results. And for instance, in the Netherlands, it's a standard now that postoperative superficial hyperthermia and radiation is given when there is a local recurrent what was inoperated, and they have a local regional control about 70% in their studies. And also a meta-analysis from data showed the same thing, that previously irradiated patient salvaged with a local retreatment with hyperthermia have a much better local control. This was one of my first patients when I was a young doctor, 83. And now everybody says Dr. Notter is always showing the same horrible pictures, but it's life, it's reality. I see this every year. A lot of these patients. Means a very, very intensive therapeutic challenge, of course, a lot of efforts to do to help this patient, and care is unfortunately done not really organized in some dermatological clinics, endocrinological clinics, or in station hospices. So it's not really very well organized. And are these patients now really out of therapy, or can we still offer something then? And radiation with reduced radiation dose and superficial hyperthermia at least offers a certain help to these patients. And we have also some trials which I can show you here. We have only three randomized trials which had clearly shown a benefit of radiation and hyperthermia compared to radiation alone. And we have also a lot of non-randomized trials. I just put those with a large number, and you see also there we have a consistent, better local control. We have some toxicities, of course, but we can still, let's say, this works. If we go to some technical requirements with, let's say, small local recurrence, for me it's a small local recurrence, we can cover that relatively easily with microwave treatments. But if we have just a microscopic disease after a mastectomy and we just want to treat the scar, it still works. But if we want to treat the whole chest wall, it will be difficult. We have already technical limitations. And if we have such an extended disease, then of course we are lost with this technique. We can try to do a so-called patchwork technique. That means we can give a large radiation field. This is possible technically. And then we are just adding hyperthermia by step by step. It's possible, it's a lot of work, it works a little bit, but not very good. This is an example from Aarau when I worked there. It's rather complicated, and we have the danger of over or under dosage. So we have to think about another technology, and this is infrared. Infrared sources, you can increase the distance and you can cover larger fields. And what the advantage is again with infrared is that you can measure the surface directly, so we can control the surface by another infrared camera. And if you combine this together with a computer, it's an technically easily hyperthermia system. The disadvantage of infrared is it's less penetrating than microwaves. You're talking about 2 centimeters covering the surface to heat up. The machine itself, it's an easy construction in a way. You see here the setup. We can measure the temperature. We can control it by thermography, by picture, and by curves. And it's also a very flexible machines for different treating positions on the back, on the sitting position, on the side, depending on the extensions of the tumor and the patient's possibilities. Important is for me that hyperthermia is given together with radiation simultaneously if possible. This is shown already in 40 years old data by Overgaard. I can show you just one example of a simultaneous treatment we did in Aarau at that time. Just 2 sessions of 4 gray once per week, a complete remission, if we can really apply it simultaneously. Unfortunately, this is not easily possible with new machines, so we have to think a little bit differently. And we have also to say that timing is controversially discussed in the literature. If we are trying to get an reoxygenation, the effect is lasting just only some minutes. So it's very important to put 2 treatments together. If you are thinking about DNA repair inhibition, then maybe the effect is about 1 or 2 hours. Then we can, of course, afford also to do hyperthermia in one clinic and the radiation in the other clinic. And if there is a direct destruction effect, then maybe the same thing. So the most frequently used schedule is up to now primary radiation and then hyperthermia when you have time. But if you are really limited with your radiation doses, try to apply as close as possible these two treatments. So a near simultaneous approach, and this is what we said. Well, I said before, this is my Notter schedule. I try to do the maximal effect is immediately putting the two treatments together, starting with hyperthermia. This takes time to heat up, and then you can irradiate immediately after that. And this is, for instance, a situation I showed you before, a patient who had already former radiation. Then she had next radiation because it was still a painful situation, then again radiation. So from the radio-oncological point of view, you can no more irradiate. It's over. What we are trying is to heat up and then to give a low dose. And this low dose within some minutes. And this is the schedule. I just give 5 treatments per week, 5 treatments once per week with hyperthermia, and immediately within minutes radiation. So a low dose radiation and together with hyperthermia. But timing is very important. So we are just organizing it in your clinic differently. We heat the patient, then inform the team on the LINAC that she had to be prepared. And then the patient is taken by the technicians, wrapped by a preheated blanket and put to the table. We call it speedy positioning, so not losing time, just take the necessary precision you need and then treat and start. Of course, it's important to know what you are really doing. So prescription of local recurrence is sometimes diffuse, and that's the reason we tried to propose a new classification of a simple and reproducible classification, how to judge a local recurrence situation. And if we go to our results, you see that we had with this method about 201 patients a very high complete remission for almost all patients, let's say in class 1, 2, 3, class 4. That means the typical cancer acquiras with the tumor growing around the chest wall. There, of course, we could not really obtain a complete remission. But we can say 95 of these patients responded. That's quite important considering that they have all been treated heavily before. But for the patient, it's more important, is this complete remission also holding on? Because complete remission is one thing, but if you have a recurrence within some weeks, then of course it's nothing. So we analyze that, and what we can really see is that local control is maintained in about 2/3 of this patient, independently of the stage before. Only the class 4 patient had a local recurrence. And the same thing is also for the partial remission. That means more than 50% regression of the tumor after the treatment. And also here we can say that to almost half of the patient remain in this situation during their lifetime. That means that's a very good indicator that the quality of life of this patient is improved and can also be maintained. And the toxicity is very poor. We had about 50% of the patients without any acute toxicity, and also chronic toxicity was very, very low. And if we go to the survival curves of this patient, I just wanted to show you something. These patients are not always lost, because some of them never had any metastasis but the local recurrence and will succumb of the local disease. And if we see now, if we can control the tumor locally, we have also some of them which are surviving with a good quality of life. So just as a summary, we have an overall response about 95%. We have a response also in ulcerating tumors, which is about 90%. So therefore there, a very good response. We have a local control during lifetime of the complete remission, about 2/3, and also half of them remain controlled or stabilized during their lifetime when they have a partial remission with a very low toxicity. I just give you some examples, a patient before and after. You see with 2 series we have a very, very good response, and also with this technique, no complication with a portacathes, because it's a metallic implant, which is not a difficulty with hyperthermia, with Vira hyperthermia, with infrared hyperthermia. This was a cancer acquiras, just with 2 months after the series before and on the back of the patient with almost a complete remission. Another young lady with a bilateral recurrence, treated again with 5 times 4 days, once per week, and hyperthermia. Very good palliative effect. For her, it was sufficient. And here in a triple negative breast cancer, also with a very, very good response after this treatment locally. Patients coming to you with a local recurrence have a bag, a large bag, because they have to cover themselves, to care themselves. So they have a mirror. She has some material to wound bandage and things like this. So that's their daily life. They cannot go out only with that. And if you are treating them, you have to take care about that they get again a wound bandage as well. So what we analyze is also a bit how can we improve that. And if you look this daily expenditure of time to do special bandages, to avoid super infections, to have a decaying tumor, try to not to have this odor, or try to look for special shower heads and things like this, or questions, can I go out? Who helps me at home? Are there some economical impacts, quality of life, of course, the psychological situation, and so on and so on. This is very, very important. We looked for these ulcerating tumors. There were 70 before the treatment, and we could see that 93 of them had a very good response as well. So with a reduced need of bandages or even no bandages. What does that mean? You see here a partial remission after treatment. And if you look her 1 year later on in the follow-up, it's still dry. She doesn't need any bandage for the moment. There is no odor, no more decaying tumor. It's not closed, of course, but it's for her manageable to go outside. And the same we can see with the need of analgesic as well. So also there we see that we could reduce this need of analgesics. As a medical doctor, we know that sometimes you are not so good. We have also the problem to do a radiation-induced tumor. And this hemangiosarcoma after breast cancer treatment is now increasing more and more because we have also more breast cancer treatment. And these tumors are extremely aggressive. You see here an example, just the 4th recurrence before she was sent to me. And the question was, can you re-irradiate a radiation-induced tumor? Everybody would say, no, of course, are you a fool? But what can we do? And we did. And together with hyperthermia, we could achieve a very good local control as well. And you see also here the aggressivity of this tumor. This was just the preoperative situation. They did a mapping to be sure that they do the mastectomy correctly all around this visible manifestation, about more than 10 centimeters. She had enough tissue, fortunately. She came to me after the treatment to discuss about the postoperative radiation and hyperthermia. You see already the first recurrence was there, verified by biopsy within 3 weeks after the mastectomy. So extremely aggressive tumor. And you see here now the follow-up of 4 years. After that, no local manifestation at all. So as a conclusion, I can say this treatment method is very, very effective as a palliation method, of course, with a high remission rate we can obtain, and these remissions can maintain for a lot of this patient for lifetime. And it is done on outpatient basis with a very low toxicity. It improves quality of life very effectively and can even be repeated in some situations. And the extreme low dose radiation, the timing, of course, is very, very important, but it's not inferior compared to the other results compared from the literature with higher doses and microwave hyperthermia. And I think it's definitely a huge potential to help these patients with a very relatively well-tolerated, effective and easy way, in addition with a rather low economic implications as well, for locally recurrent breast cancer, for locally advanced breast cancer, and also, of course, for radiation-associated angiosarcoma of the breast. And as already established now in Switzerland, superficial hyperthermia and radiation should be really accepted as a new standard in specific situations, in addition to all other efforts we are doing. So thank you very much for your attention.